Welcome to CleanMedKE, where we make clinical medicine and surgery clear, structured, and clinical. Today, we're diving deep into clinical iron pathways, exploring how the body absorbs, transports, and regulates this essential yet potentially dangerous element. Before we begin, please note that this content is for educational purposes only and does not constitute medical advice. To understand iron, we must first understand its dual nature. Iron exists in two main states, ferrous, Fe2+, and ferric, Fe3+. Think of Fe2+ as the form that goes into the duodenum because it is soluble and absorbable, but it's also highly reactive. On the other hand, Fe3+ is the predominant dietary form, but it is insoluble and requires conversion before the body can use it. We have to be careful because free Fe2+ can participate in the Fenton reaction, reacting with hydrogen peroxide to create destructive hydroxyl free radicals. This is why the body ensures iron is always safely bound to a protein. Our journey begins with what we eat. Iron comes in two flavors, heme and non-heme. Heme iron, found in animal sources like meat and blood, is stabilized inside a porphyrin ring and is highly bioavailable, with an absorption rate of up to 35%. Non-heme iron comes from plants, like spinach and lentils. It is predominantly in the Fe3+ state and has much lower bioavailability, often requiring reduction to Fe2+ before it can even be absorbed. The environment in the gut determines how much iron actually makes it into your system. Enhancers like stomach acid and vitamin C are vital. They prevent Fe3+ from forming insoluble crystals and provide the electrons needed to reduce it to the absorbable Fe2+ state. Conversely, inhibitors can block this process. Proton pump inhibitors, PPIs, destroy the necessary acidic environment, while calcium, phytates in legumes, and polyphenols in tea or coffee can bind and chelate iron, carrying it straight out into the stool. At the apical gateway of the enterocyte, we see two distinct pathways. For non-heme iron, Fe3+ must be reduced to Fe2+ by an enzyme called DCYTB, using vitamin C as a helper. It then enters the cell via the DMT1 transporter. Heme iron has a dedicated entrance through HCP1. Once inside the cytoplasm, an enzyme called heme oxygenase breaks down the ring to release the iron. Once iron is inside the cell, it reaches a crossroads: storage or export. If the body doesn't need it immediately, iron is oxidized back to Fe3+ and trapped inside a cage-like protein called ferritin. This is a crucial exit strategy for the body because we have no active way to excrete iron. If it's trapped in ferritin, it simply stays in the cell until that cell sloughs off and is lost in the feces after about 3 days. If the body needs iron, it must pass through the basolateral gateway. Ferroportin is the only cellular iron exporter in the human body. It is the exit gate. As Fe2+ exits, it is immediately oxidized by hepcidin into stable Fe3+. From there, it boards transferrin, which acts as the taxi, transporting iron through the plasma to where it's needed. When the iron taxi reaches a target cell, like a developing red blood cell, the transferrin cycle begins. It docks at the transferrin receptor, TFR1, and the entire complex is swallowed into the cell via an endosome. Inside, an acid drop causes the iron to fall off the taxi, where it is pushed into the cytoplasm to be used. The empty taxi and its receptor are then recycled back to the surface to start the process over again. Here is a core insight. Most of your daily iron doesn't come from your diet, it comes from recycling. Macrophages in the spleen and liver consume old, senescent red blood cells. They break down the hemoglobin, use heme oxygenase to extract the iron, and then export it back into the blood through that same gate we saw earlier, ferroportin. So who controls the gates? That would be hepcidin, the master regulator produced by the liver. Hepcidin acts like a hammer. It binds to ferroportin and destroys it, effectively trapping iron inside cells. High iron stores or inflammation, driven by interleukin-6, will activate hepcidin to block iron flow, while iron deficiency or hypoxia will inhibit it to allow more iron into the system. In the clinic, we use 4 main tools to track this pathway. Serum ferritin measures your primary storage. Serum iron measures what is currently in the taxis. TIBC, total iron binding capacity, a proxy for the total number of taxis available. Note the inverse relationship. When iron is low, the liver makes more taxis to try and catch every bit of iron available. Percent saturation tells us how many seats on those taxis are actually full.
We can use these markers to distinguish between conditions. In iron deficiency anemia, IDA, everything is low except for TIBC, which spikes as the body hunts for iron. In anemia of chronic disease, ACD, inflammation spikes hepcidin, so iron is trapped. This leads to high ferritin, but low serum iron and TIBC. Finally, in hereditary hemochromatosis, a lack of hepcidin leads to uncontrolled absorption, pushing percent saturation toward 100%. To wrap up, remember the big picture. Iron enters through the gut, travels through the blood on transferrin, and is used by the bone marrow. The spleen recycles it, and the liver acts as central command, sensing systemic needs and dropping the hepcidin hammer to shut down the network when necessary. Thank you for joining us on The Pathway today. If you found this clinical breakdown helpful, please like, share, and subscribe to CleanMedKE for more clear, structured medical education. See you in the next one.